Yeah, so good evening. Today I'm presenting one case of long RCA CTO, Pre-Crux CTO with an ambiguous chords, which we tackled with knuckle wiring and reverse cart. I'm Dr. Sharath, interventional cardiologist from Medicover Hospitals, Hyderabad. So my patient is a 53-year-old male, status post PCI with a death to LCX and LAD in 2006 for acute coronary syndrome and failed PCI during same sitting, failed RCA PCI. He presented with acute inferior ST elevation MI and cardiogenic shock a month before, for which restenting was done to LCX and LAD, which I will show now. So these are the angiogram pictures during primary PCI. So RCA is totally occluded, so which we can witness here, and left circumflex is totally blocked. It's a stent thrombosis, and left anterior descending artery is also tightly stenosed. It's almost 70 to 80% lesion. So during that acute event, LCX thrombosection was done and restented with the 3.5 and 28 millimeter stent, and this is the post-stent result, which is quite good. But two stents jailed epicardial collateral, and this is LAD lesion which was pre-dilated and stented with 3 into 15 millimeters with a good result, and SEPTALs are also occluded by two stents, jailed by two stents. So this is the anatomy of right coronary artery CTO. So you can see, so proximal cap is good. There is a clear entry point, and the distal cap is almost at the crux, and we can clearly see there is an ectasia of the vessel immediately after the crux. This is the ectasia, and these are the two branches, and into which branch these collaterals are entering, septal collaterals are entering, is not clear due to predominant epicardial collateral flow. And coming to the calcium, there is calcium visible in this area, and it is also angulated segment, and course is not clear. So coming to the JCTO score, you can clearly see there is a clear entry point, and there is a calcification, and there is good angulation, almost more than 90 degrees, and the length is also more than 20 millimeters, and it's a retrial lesion. So a total of 4 is the JCTO. Yeah, and coming to the collaterals present in this case, there are two collaterals. One is epicardial collateral. You can see it is dividing into two and joining at PLVB. So the size is good, though there are multiple loops inside the collateral, but the origin is tightly stenosed. And septal collaterals, the first septal collateral is actually cranial in course after origin. So the entry point is a little bad, but the exit is okay. But we are not able to make out into which branch it is opening. And second collateral, the entry is good, entry angle is good, and also the exit angle, but into which branch it is opening is not clear. So coming to the wiring strategy for this anatomy, so there is a clear cap and good distal target and unknown course of the vessel till the crux. So, and interventional collaterals are quite good. So both either retrograde or an antegrade dissection re-entry can be attempted, as there are no big branches in CTO. We opted for antegrade dissection. So this is the antegrade dissection and re-entry plan for this patient. So the first point is choosing a re-entry zone. So this is a clear re-entry zone for this patient, ectatic segment. So that is here. So we can re-enter here. There is a small branch, which is too small. And next is dissection, where from we can dissect and where to end. That's a dissection plan. So I planned dissection from this point, that is 3 to 4 millimeters after entry point. So you start dissection here with a knuckle wire, and once knuckle comes here, that is pre-crux 4 to 5 millimeter before crux, then switch to bogey technique, that is push the microcatheter here and switch the wire to Gaia 2 and then advance till the re-entry zone for dry re-entry. So this is a dissection plan and this is a re-entry plan. Re-entry is with Stingray. And coming to the support for ADR, so we plan to take a amplitude antegrade guide with balloon trapping of microcatheter for adequate support for knuckle wire. So yeah, this is the ADR plan. And during PCI, so this is a dual injection which we gave, so which clearly delineates the anatomy. And you can see I placed microcatheter, that's corsair, antegradely into the total occlusion segment, and there is another wire into the side branch. So we did trapping of microcatheter with I think 3 balloon, 3 into 12 balloon, and then we took a filter XTR wire and knuckled it, but unfortunately that knuckle went into side branch again and again. So you can see then we widened the knuckle, but despite wide knuckle only went into side branch, which we can appreciate in both RAO and LAO views. So at this stage we switched the strategy to retrograde, and epicardial collateral was tried first, but I couldn't wire epicardial collateral as the origin is tightly stenosed and it is jailed by 2 stents here. So then I switched to septal collateral. So first septal collateral couldn't be wired, so I went into second septal collateral, so which is a bit a good entry angle and also the exit angle, and used a cyan wire, so with which we could cross septal collateral. So you can see here, and see once caravel is advanced to the crux, so we took an injection to see the distal RCA segment. So there is a good little flow into distal RCA, but the wire is getting looped into the ectatic segment. So that's when we started retrograde wire escalation. So initially I tried with fielder XTR, but as this wire is floppy, it was just looping into the ectasia. So we escalated to Gaia 2 which is more directable. So, and we directed Gaia wire into the mid RCA. So it just went. So after retrograde wire in mid RCA, we escalated antegrade wire to Gaia 2, and we can see both the wires in LAO and RAO. See, these wires are not converging. So I switched retrograde wire to more flexible but similar tip load, that is Pilot 150, but still both the wires are not convergent. So that's when we were a bit doubtful. See, though both the wires are moving in typically with the RCA motion, so they are not convergent. So we thought of going ahead with retrograde knuckling, as the course was a bit unclear for next step. This is we use retrograde knuckling as I already failed in antegrade knuckling in the beginning. And where to start retrograde knuckle? So it's better to start before this loop, because that is what is causing confusion, of course. So start before loop and end 5 to 6 millimeter beyond the proximal cap. So that is to make your reverse cut more easier. So this is the starting point and this is the end point of knuckling, and this is the reverse cart. That's a conventional reverse cart. So this is the plan for retrograde knuckling and re-entry. So we did retrograde knuckling with the pilot 50 wire. You can see the microcatheter is just getting advanced over the knuckle, and further advancement of knuckle here, and we further advanced knuckle up to this point as planned, 4 to 5 millimeter beyond the proximal cap. So, and microcatheter is advanced, and you can see here microcatheter is moving along the RCA wire, but if you see the antegrade wire and retrograde microcatheter, they are widely separated. So, but they are within the vessel architecture, so which we can see by the movement of the wire. So at this juncture we switch to conventional reverse cart. So this is the balloon with a 2.5 millimeter 12 millimeter with a retrograde Gaia 3. So Gaia 3 is directed in both LAO and RAO views towards the balloon, and pushed forward while retracting balloon, so with which we entered into true lumen. We can see here now the Gaia 2 is just entering the antegrade guide. Yeah, it entered antegrade guide. So we externalized wide and then dilated with a 1.25 mm balloon and did an IVUS. So which showed I am in subintimal immediately before crux. So though I knuckled from here, so my course was subintimal up to here. That means my retrograde wire escalation to Gaia 2 actually went through subintimal from here, so immediately prior to the crux. So in entire area I am in subintimal space. So you can see here also this is a true lumen and this is a false lumen, but there is no footprint of knuckle here. But here you can see this is the knuckle footprint. So there will be wide subintimal space and narrow true lumen. So, and this is again at the re-entry, that's a reverse cart area. So you can see this is a true lumen and this is a side branch wire, and this is a RCA wire. So, and this is where both the wires are in true lumen, so we re-entered into true lumen. So this is where exactly we re-entered into true lumen. So, and this is a final result for this case. So after 3 stents from crux to ostial RCA, so we achieved a good result, and these are the final IVUS minimum stent areas. So it's distally it's 5.4 mm square, and proximally the minimum stent area was 7.4 at the site of calcium. So to conclude, ADR as first strategy can be used with a bailout strategy in hand if failed. Antegrade knuckle as dissection strategy can fail to progress in presence of side branches, as in this case. Consistent antegrade retrograde wide divergence needs course confirmation for further continuation. Knuckling circumvents course ambiguity, but when knuckling is used, define start and end zones of knuckling along with re-entry strategy. It's reverse cart in retrograde or true lumen re-entry in antegrade. Define your reverse cart strategy before retrograde knuckling. Thank you.